have you thought about what you want your death to look like? Or have you thought about what your child's death to look like? We don't see normal things. We don't do normal things. I think in our death-defying, death taboo culture, we don't create space for people to share their thoughts or worries about dying. Back in the day where most times people died at home and people saw what normal dying looks like, we have no idea anymore. I think most people have never seen somebody die.
Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare profession. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways they are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted, yet so profoundly impactful.
Hello, everyone, and welcome back to Muted in Medicine, the podcast where we break the silence on untold stories in healthcare. My name is Saba Fatima, and I'll be your host for this podcast. I'm a pediatrician with a passion for helping healthcare professionals facing secondary trauma at work in healthcare, which often they're unprepared to face, and spreading more awareness about it. Today's conversation is about a subject that every physician encounters, but few feel prepared for: death and dying. In medical school, we're trained to save lives, to fight disease, to never give up. But what happens when cure is no longer possible? When the role of healer shifts from prolonging life to easing suffering? My guest today is Dr. Jared Rubenstein, a pediatric palliative care physician who has spent his career helping patients and families navigating some of the most difficult conversations in medicine. Together, we'll talk about why physicians are often uncomfortable with death, how our training leaves gaps in preparing us for these moments, and what palliative care really means beyond the common misconceptions. This episode is an invitation to rethink how we approach mortality, not as a failure, but as a part of life, deserving of honesty, compassion, and presence. Dr. Rubenstein is a pediatric palliative care physician and medical educator at Baylor College of Medicine and Texas Children's Hospital in Houston. As a fellowship director, he trains the next generation of clinicians in person-centered care, serious illness, communication, and antiracism. He's passionate about making hard conversations easier, often using humor, satire, and animation to break down barriers. His YouTube channel, with over 150,000 views, shares original videos on topics from serious illness to gender equity and is used worldwide as a teaching tool. Dr. Rubenstein, welcome to the show.
Thank you so much for having me. I'm really looking forward to this conversation with you.
Yeah, thank you. I know we've been wanting to do this for a while, so I'm glad that we are finally able to do it. We ask everybody when we start, what's bringing you joy in medicine today?
For me, I think so much of it is the team I get to work with. It's some of the best people I've ever known. And palliative care, sort of by definition, is a team sport. And it really only works for the patients and families if you're doing it together as part of a group with interprofessional teammates. But I think also for ourselves to be able to do this work alongside other people all the time, I think is huge.
Yeah. And I think it's hard. Like, the work you do is hard. Let's acknowledge that. I think healthcare in general is hard, but yeah, palliative care probably adds another layer. So I would want to impact that. How I usually like to ask, what's your journey? Why did you decide to become a palliative care physician?
Yeah, so it was a little windy. I never set out to be a doctor at all. And but growing up, my dad was an adult pulm critical care doctor and my mom was a social worker. And our dinner table conversations would be like little interdisciplinary team meetings. And my dad would often talk about his work and his patients, but it wouldn't be the heroics of ICU. It would be about, having hard conversations and supporting people at the end of their lives and talking to patients and families about what was going on with them. And it always just stuck out in my mind as really worthwhile work, but didn't think about it for myself because I didn't even think I could go into medicine. And then later found my way kind of back to medicine through sort of a windy path. And when I started medical school, realized that even though my dad didn't sort of have the word for it at the time, he was talking about palliative care. And I did an elective and just loved it and was all set to do adult palliative care. And then I did my pediatrics rotation and loved that. And I thought, is pediatric palliative care even a thing? And it wasn't at the time where I was a medical student or a resident, but was able to do a visiting rotation at another program and just loved it. And that was what I decided to do.
You said you loved it. Was it difficult though? Like the conversation about death and dying and children? Yeah. Did you ever come across that?
Oh, absolutely. I mean, I think it's hugely emotionally challenging work. And that's also part of what I really like about it, that I think it helps it feel important and worthwhile to create spaces for the stuff that people don't like to talk about, sort of like your entire podcast. Yeah. And I think we also, because of the nature of the work, I think adopt a lot of coping strategies that we do. We help each other with sort of having them personally and then also having them as a team. And people always assume that when they come rotate with our team on an elective or meet us, that we're going to be sort of these sad, timid, broken people. And then they always say how surprised they were at how much they enjoyed their time with us, how much they enjoyed having lunch with our team, how much they enjoyed spending a few weeks with us. And I think that's a big part of it. And while our work may be uniquely sad, it's certainly not the only specialty that comes across difficulty and sadness. And I think my one ask and hope for medicine in general is that they help each other to normalize that, like, we all see hard stuff. We should talk about it together. We don't have to suffer alone.
Yeah, I love that. Yeah, thank you for saying that. So do you think that we don't train enough for death and dying? And that was kind of the premise of this episode, that we don't know enough about death and dying. I think personally, like in my experience, like I don't think my training prepared me for it. I was very uncomfortable with it, very, very. And I had to learn a few things on my own. So do you think that exists, and why does it exist?
Yeah, absolutely. And I think it was interesting the way you worded that we don't know enough about it, that we, like the field of medicine very much knows a lot about it. Like there's a huge, robust body of data about what dying looks like, what normal dying is, how to care for people and support them at the end of their lives. But we just don't talk about it and teach about it. And it's not for most of us until we do, say, training in a palliative care fellowship that you start to talk about these very normal, very common things that medicine kind of shies away from. And I think heard somebody said once, most people will never have a baby, but almost all medical students spend weeks or months doing OB, and every single person at some point will die. And most medical students learn nothing about taking care of people who are dying.
Yeah. And why do you think that is? Is it because as a society we're uncomfortable with that? Do you think that's why?
I think that's a big part of it. I certainly think dying to some extent is un-American, like it's something that other people do. And I think other countries and cultures certainly talk and have more healthy attitudes and sort of normalize the everyday presence of death in life better than we do as Americans. So I think that's a part of it. And I think it's compounded by our healthcare system, that death is not only, it's a taboo, but it's a failure, that we've done something wrong, that with all our technology and medicine and science, we should be able to save everyone. And when we can't, the normal American taboo and discomfort talking about it is compounded by the personal feelings of failure, that we did something wrong because we couldn't save every person we took care of.
How profound. Yeah, that's so important. I never thought of it that way, yes, because I think we're maybe uncomfortable with it because, yes, we're taught how to save everyone, and, that brings up our own imperfections. So, yeah, that's a great point. And does it kind of frame how we talk to families? So I think that came up with me as well, because I wasn't comfortable with that. Talking to families is like a big deal, so nobody taught me in residency. Here I'm in attending life. I don't know how to have this conversation. And, in the first few years of me being an attending, we used to take care of complex oncology patients. And there was a patient who was going towards end of life. And I was there at the middle of the night. I was like, I have no idea, how I'm going to talk to this family. So does that happen as well?
Yeah, absolutely. And I think nobody wants to do a bad job with it, and everyone wants to do right by their patients, but they're just unequipped. And most of us have never been taught, and especially for like in general pediatrics or hospital medicine that you practice and I used to practice, that it's very foreign. But even in fields where children die with some frequency, like ICU and oncology, it's something that in general people don't get taught. We get taught a lot how to prevent people from dying. But when, despite everything we do, we can't save someone's life, we're really unequipped both of how medically to take care of someone who's dying other than doing CPR, but also socially how to take care of someone who's dying.
Yeah. And do you think it's more across the board, like in both adult and children, like pediatrics, or is it most pertaining to pediatrics?
I think there's definitely something across the board that both it's the cultural problems are there in adult medicine, the personal failures and feelings of having done something wrong are there in adult medicine. But I think it's also compounded in pediatrics by, I think there is something that most people understandably feel like there's something wrong with the universe if a child is dying. Like it's not supposed to happen. And as much as in America, maybe we feel like nobody's supposed to die, we for sure don't feel like children are supposed to die, and they shouldn't. And yet we live in a world where they sometimes do. And I think I'm always struck when I'm taking care of a dying patient in a children's hospital, especially if it's on a unit where children very infrequently die, that one of the miracles of modern medicine is that children don't die very often. But when they do at a children's hospital, it sometimes feels like every time it's the first time a child has ever died in that hospital. And often it may be, especially in a unit that doesn't have that experience a lot, that the doctors, nurses, social workers, chaplain of that unit may not be used to taking care of people that are dying, and also not be equipped with the tools to support and care for someone. And I think that's a big role of our team is sort of being there and being that team that unfortunately has a lot of expertise taking care of children at the end of life and can be there to be sort of that constant presence. And despite that, I also still feel like it's crucially important to have this be knowledge and understanding and have a competence throughout medical fields.
Yeah. I'm curious, how do you personally make peace with that? Because you said, it's against the natural order for children to die, and you feel the same way, I feel the same way. So, but it sounds like you feel more confident and competent than I do. So how do you personally make peace with that?
So part of it is maybe my sort of spirituality and my existential beliefs about the world, that I don't have the angst about, why do bad things happen to good people or everything happens to a reason. I don't feel like that. I think bad things happen a lot, and sometimes they happen to good people, and I don't think things happen for a reason. And so there's not a sort of a making sense of, or that something fundamentally wrong has happened, as much as just the sense that something fundamentally sad is happening and heartbreaking, and that we should be doing everything we can to try to help it, because it's going to happen either way. And avoiding it or pretending like it's not happening and not talking about it and not teaching each other about it, I think only makes it worse.
That's important. That's a good point. Did you have a time in your training or when you were going along in your career where you're like, I'm not comfortable with this conversation?
Oh, 100%. And I think so much of my desire to go into palliative care was a combination of my own failures and watching the failures of those around me, that it really seemed throughout medical school and residency that we just really didn't know how to take care of people who aren't going to get better. And that there was a collective sort of throwing our hands up or just feeling so sad that we can't do anything about it, and not realizing that you actually can do a lot about it. Like, I think, the phrase like that in all of us in palliative care kind of grates on our nerves. There's nothing more we can do. Because of course there is. Just because we can't save someone's life, there's still so much we can do for them to make the end of life as peaceful and calm and sort of full circle as they deserve, whether it's an adult or a child. And I think for me, sort of a wake-up moment of sort of how I had been jaded by medicine that always sticks out of my mind was in residency. We were working overnight, and it was me and my co-senior resident and some interns and then a couple medical students. And we had sent the medical students down to the ER to go do a consult. And they were gone for a while, and they came back and they said, we were down there doing our consult, but then a patient came into the trauma room. And so we went to watch, and we saw that child die. And so, like, after giving a beat, I said, oh, wow, okay, so tell me about your patient presentation that you saw. And not even feeling like that was horrific. And my co-resident, I'll give a shout out to Beth Dawson-Hahn, who's fantastic, said, before we do that, are you guys okay? Like, let's talk about what you saw and talk about what happened. And I was like, wow, it took that to realize how, I think, inculcated and jaded I'd been by the system, that like, you just keep moving. You have to keep going on to the next thing, and how wrong that was.
Yeah. Yeah. And then you notice something. I feel sometimes, I can't strike the balance if you feel too much or if you feel too less, like, you have to, like, you can either be robotic and not feel for the patients, or if you feel too much, then you affect yourself personally. So I always struggle to find that balance. And I don't know if you do, but
Absolutely.
You're in a better place now, but yeah.
Yeah. I mean, I think that's always a struggle to some extent, but I think when I remember being taught sort of about the difference between empathy and compassion, and feeling like that's kind of a helpful framework, that empathy is just, you're feeling with this people and you're feeling their pain, which there's huge value in. Like, I think empathy to some extent makes the world go round. And it's also kind of a helpless feeling if you're in a situation for something that you feel somebody's pain and you can't do anything to help. And so where compassion comes in, it's sort of like the action motivated component of empathy, that you're feeling for somebody and you're going to try to do whatever you can to make something better. And it doesn't mean doing treatments that aren't medically effective. And it doesn't mean offering people straws to grasp at when there are no valid straws left, but it means naming it and being with them. And sometimes it's just the being present that's the treatment. But also oftentimes there's a lot of medical treatments or supportive care that can be done, even when the goal is not curing.
Yeah. And personally, like, how, if somebody is listening to you, you talked about those feelings of failure and that you can feel, how do you get past that? Like, what would be your message to, people who are struggling with that, death feels as a failure and now I can't do further,
Yeah, to some extent, I think it's not an individual problem. I think as individuals, we need to work on it. And I'm a huge proponent of mental health support. And I think every doctor should have a therapist they can talk to and trust to kind of process that. And I think we need to normalize as a system that, like, to not be the resident that I was that night, and be more like my co-resident, where when these things happen, don't just rush off and do the next thing. Say like, wow, like and as attendings, I think we can model that. Like, this has felt really hard. Like, why don't we take 5 minutes and sit and talk about it before we rush off and do the next thing? And to some extent, I know 5 minutes will sound like it's never enough, but it's so much more than 0, which is the norm. And I think starting from the top and seeing it role modeled so that the next generation, and I think the next generation, I think already is a lot better at it. I think there's the sense that, like, a lot of the stuff we do in medicine is kind of inherently bizarre, and that we've all sort of been victims of that's how it was in my day. And so we just keep doing it. And I think to some extent, the younger generation is already better at helping us open our eyes at seeing that, like, some of this isn't normal. And if we can let ourselves get to the place where they're not just complaining millennials, but people with like a different valid viewpoint that probably can be married with ours in a way to maybe heal medicine to some extent, I think that would be great.
Yeah. Awesome. Tell me more about palliative care, the work that you do, and what are some of the common misconceptions around it which you wish that were not there?
Yeah. And so for me, the way I talk about palliative care and the way I tell patients and families when I'm meeting them for the first time is that, while there's heart teams and lung teams and GI teams, like, our team is kind of a whole person team, that when there's a serious illness, there's physical suffering, there's emotional suffering, there's spiritual suffering. And our job is to help with all that. And that's why we have a big interprofessional team. We have doctors, we have nurses, we have social workers, we have chaplains that all kind of be part of that whole person care. And some of the specifics we do, we can help with pain or symptom management. We can help out planning for the future. And, it's families get asked to think about really hard things, and they get asked to make impossible choices that sometimes have life and death consequences. And we see over and over how isolating and lonely it can be for families, aside from the heartbreak of thinking about it. And part of our role is to kind of help them navigate these choices. And we do that, and that we have to make sure we're doing it by their values and not ours. And so we spend a lot of time talking to them, and sort of the medical jargon for it is goals of care, that people always say, we have to assess goals of care, but I don't think people always know what that means. And to me, it's like somebody's values, it's somebody's hopes, it's somebody's fears, it's somebody's priorities. It's all the stuff that's most important to them that they want for their healthcare that we can talk to them about. And then through shared decision making, kind of help marry it to what we understand about the medical situation to help them kind of pick a way forward. And we focus a lot on quality of life. We focus a lot on support for the patient and the family. And we also do take care of patients at the end of their life. And I name that almost always and don't shy away from it because, one, I think it's important people know. And while, we meet, ideally, palliative care gets consulted from the time of diagnosis of a serious or life-threatening illness and not at the time of dying. But we also have expertise in taking care of people who are dying. And I often name that part when I talk to patients and families because, one, I don't want them to look on the internet. And because of all the myths and misconceptions out there, if you look up palliative care on the internet, often the first thing you see is death and dying. And I wouldn't want them to think I was hiding something from them. And two, I think sometimes people really do want to talk about that and they haven't been given permission, whether it's the patient or the parents or family members, that I think in our death-defying, death taboo culture, we don't create space for people to share their thoughts or worries about dying. And I want people to know we're a safe space to do that if that's something that's on their mind. And in terms of biases and myths and misconceptions, I think there's so many. I think there's still the sense that, quote, people are afraid of palliative care. And to me, I think we're a group of nice people that are going to help them feel better. Like we're the least scary thing in the world. But because there's this sort of tie-in that we're the death team, it makes people scared that because we're involved, something's going to happen. And I think the data that's been really enlightening for me is that there's this sense in healthcare that, quote, people are scared of palliative care. And when you look at the literature, it doesn't really hold up. Most people just don't know what palliative care is. And then when they hear what it is, most people think it sounds great. And so for people that do have a negative bias, oftentimes when in studies, when that population is kind of drilled down to and interviewed more, it's found that those negative biases often come from the medical teams, with people saying things like, I know palliative care is really scary, but don't be scared. And the family's like, well, I wasn't scared, but now I'm totally scared because you told me not to be scared. Or saying things like, I remember I was in a consult once and the patient's mother in the middle said, I'm really enjoying talking to you, but can you tell me why your team has a bad rap? And I said, I'm sorry, I didn't know our team had a bad rap. What do you mean? And she said, well, the doctor that said they were calling you said, we're calling palliative care. I know they have a bad rap, but don't worry, it'll be okay. And I said, I think we have a bad rap because people say stuff like that. And there's still the message about, we hear, I've been walking into a room and I've had doctors put their arm out to bar the door and saying it's not time yet, or don't take away hope. And all of these things are hurting people. And it's all well meant. Nobody's doing it from a place of ill will. And they're still hurting people and causing problems because of their own discomfort.
Yeah, that's interesting. Do you think that the families sometimes shy away, and because they also think that this is? Have you had families be like, "Okay, no, I don't want to do this right now"?
Absolutely, yeah. And I don't want to pretend we live in a world that nobody comes in with their own preconceived notions. And there's certainly people that, when they hear palliative care, say, "Oh, palliative care, that's like hospice. My grandpa had hospice. They came over and injected him with a bunch of morphine and he died." And I'm sorry that person had that perception of that experience. But it's also, and so some people do bring that to the table, but more often than not, what I see in my anecdotal practice and what the literature shows us is that it's often people kind of come as blank slates and have the negative bias projected on them from healthcare workers with things like, I'm sorry, there's nothing more we can do, so we're going to bring in the palliative care team. It's always said with a hat in hand, kind of hung face sadness. And I always message to people what if you just totally change the paradigm? What if you said, I'm so sorry, your pain is so hard to control, but good news, we have a wonderful palliative care team at the hospital who can help take care of that pain. Or, I'm sorry that we haven't been able to cure your child, but thankfully we work with an incredible pediatric palliative care team that will make sure that they get the best care even through the end of their life. And I think it's sort of saying the same things, but with a totally different framework. And I think we have to help healthcare workers get over their own stigma and biases to be able to say that the same way that we do for other fields. Nobody says I'm so sorry you have cancer. I guess we'll bring the oncologist in. It's, we have some hard news. This looks like cancer. We work in a world-class center that has one of the best pediatric oncology teams in the world. Yeah. And we should be saying that about palliative care too.
I agree. I mean, I would say why that happened is probably because when we say oncology, it's like they'll probably fix, again, the point that they'll fix it, and calling you means might not be fixed, So yeah. Is that true?
I mean, that may be, but I think again, that's sort of a problem of framing that like oncology treatment's brutal. It's hard. You could easily say, I'm sorry, we hope we can get you better, but you're going to have to go through 3 years of chemotherapy for your leukemia, and you'll have to be in the hospital a lot. But like, why would you focus on that when you can focus on the hope of getting better? And I think it's the same thing that I would submit we are also fixing something that we help people who can't get better from having terrible deaths and not being supported and not having good pain management. And I think those are all treatable, fixable problems too.
Yeah. No, I agree. I absolutely agree. And thank you for clearing that misconception. I think we're probably like repeating this, but I think there's still a lot of misconceptions. So how early should palliative care be introduced when there's a patient with an illness? And what is all that you do? I'm just curious, like to help a patient, like just to, I think, name it out.
So I think I always think of that proverb about the tree, like when's the best time to plant a tree 50 years ago? When's the second best time to plant a tree today? I think when most people ask me about when the best time to consult palliative care is, because people think of it so late, I think it's probably a few months before you thought about doing it. But the second best time is today. And so I think, and certainly there's resource limitations, and not every healthcare center has the subspecialty palliative care capacity to meet everyone from the time of diagnosis who has a serious illness. But we should absolutely be upskilling everyone so that even if they're not meeting a subspecialty palliative care team, they're getting primary palliative care from the time of diagnosis. And I think when we meet patients and families, oftentimes it's, people think like, oh, what did you talk about? How did they respond to you? Like, did they ask you really hard questions? And oftentimes the hardest questions we get asked are, where have you been and why didn't we meet you sooner? Because when we talk to people about helping them feel better and helping them navigate a broken healthcare system and helping make sure all their teams communicate well with them and with each other and helping wrestle with impossible decisions, all those things I think are huge value adds that people feel relief to have offered to them.
Yeah. As a palliative care physician, what breaks your heart and how do you cope with that? Because I know it sounds like the death and dying, you've kind of made peace with that, but does it break your heart when maybe patients don't have the death that they wanted? Or,
Absolutely. Yeah. I mean, I think there's still, just because I don't think death should ever be viewed as a failure, if we've done what we can to try to prevent it and we're just limited by science, I think absolutely not taking care of someone well through their death is an absolute failure that we very much have the tools to do. And so that breaks my heart. I think it breaks my heart hearing the stigma that other healthcare workers have and the reticence to bring palliative care teams in. It breaks my heart too, while I've made peace sort of with the way the world is from like a medical perspective. It very much breaks my heart when things happen that I think are social problems, that we don't insure everyone in this country or that we don't care for everyone the way they deserve to be cared for. I think to me, the things that feel like they're person-made ills or person-made problems are much more devastating than medical things.
Yeah, I agree. What would you change in medical training to introduce more death and dying? And is there something that you're already doing that you would like to introduce to our audience?
Yeah, and so I think there's a lot of education out there that's available. And I think the challenge in upstream medical education is always real estate. Like, I think it's sort of like the high school teacher phenomenon that like a child's in high school and has 9 classes and all the teachers think that their class is the most important and want to give an hour worth of homework. And then the kid comes home with 9 hours worth of homework. Like, I think every specialty to some extent rightfully wants to have the most educational real estate in medical school and residency curriculums. And I think there's external pressures like the board exams that sort of constrain what things are taught and when. And I also think there should be global advocacy that I think there's still a fundamental mismatch. Like, I think for most of us who aren't going to become surgeons, spending 6 months dissecting an anatomy lab is not the right use of time to meet sort of the challenges of modern medicine. And I think having there's some colleagues of I that have brought a national program called Vital Talk to our institution. That's it's like a couple 8-hour days, and it's robust communication training around hard things. And those are 2 days that I think are so well spent. Just learn about how to have these conversations. And I easily think those 2 days could be justified in a medical school training to give people 2 days to think about conversation when we spend 6 months dissecting a cadaver and a few months looking in microscopes and doing all these things that are important to know, but to me feel like very poor use of the scarce resource of trainees' time to sort of meet the modern needs of the world. I think our team does a lot of education sort of at all the levels. So we have our own fellowship. So we're training at any given time 2 pediatric palliative care doctor fellows that'll come out and be palliative care doctors like us. But we also do a medical student elective where they come spend with our team, resident elective, elective trainings for nurse practitioner fellows or social workers or people in other specialties that want to learn about palliative care. And then I think we also do a lot of didactic stuff. So we do education sessions for the residents, for the med students, for the hospital at large to teach other people at our children's hospital about what primary palliative care is. And I think it's still not enough until we get to the point where people stop being scared to call the palliative care team and where people stop shying away from the hard conversations.
Yeah. And this is probably individualized for every patient that you meet, every person that you talk to. But I'm just curious, just for the sake of our audience and, just some basic learning, like, is there some things that you say about death and dying when you're talking to families, like a script, like something that how you make that conversation easier that you can share with us?
Yeah. And so I think it starts at a bunch of different ways. One is like sort of I mentioned from the beginning, we're open that that's something that sometimes happens and that's something our team has expertise in. And then as it gets closer, sort of, and one of my favorite people that talks about this is Dr. Catherine Mannix, who's a palliative care doctor in the UK, and has just sort of talked about reclaiming the lost wisdom of like back in the day where most times people died at home and people saw what normal dying looks like. We have no idea anymore. I think most people have never seen somebody die. And if they have, it's probably in the hospital amidst a resuscitation. And I think talking very openly with patients and families and saying, has anyone talked to you about what the end of life of what your end of life or what your child's end of life might look like? The answer is usually no. And if it's no, I say, would it be helpful if I talked with you some about that? And people almost always say yes, because what we know is that as sad and heartbreaking as it can be, it's also scarier when it's mysterious. And I think great examples are, when we talk about, giving people space to ask questions and they say, will dying hurt? And we can say, probably not. Like natural dying is not painful. And if your illness is something that's causing pain while you die, we have really good medicines and really good expertise in taking that away and in treating it. And I'll promise you that we can have good control of your pain. I think it comes up a lot when families are put in a position with a imperfectly had conversation about choosing to be intubated or not near the end of life. And when you poke down into it, even for people that say they don't want their lives prolonged by machines, we often hear that they want themselves or their child to be intubated to avoid feeling like they're suffocating. And that there's the sense that putting in a breathing tube will make them not feel like it's hard to breathe. When in reality, the reverse is true. And if it's so uncomfortable to have a breathing tube and be on a ventilator, people are usually sedated to unconsciousness to do that. And so being able to talk and say, thanks so much for sharing that worry with me. Can I tell you how we have medicines that work for shortness of breath and air hunger, so that even if you or even if your child are not breathing effectively at the end of their life, I promise they won't feel that. And I promise that we'll use medicines so that even while their body is shutting down, we'll make it so that they don't have that feeling of suffocation. And I think for a lot of people, that's really, really liberating to hear, because it's such a common fear that never really gets talked about openly.
That's very good to know. Yeah, that's important. I think I work as a hospice, and this is just so important to just listen to all of that again, and have those things in mind. And so I'm glad we're having this conversation. What does a good death look like to you from a palliative care physician's perspective?
And so for me, I think a good death is what any one person or any one family tells me a good death looks like. That it's not, I think we're learning more and more and getting away from the spectrum of defining, having like a one size fits all good death. I think in general, it should be one that has well managed pain. I think in general, it should be one where any other symptoms are well controlled. But outside of that, like I think we as a field are having an appropriate reckoning of that, where cardiology is the same in any country in the world and in any culture, and infectious disease is sort of the same. Like the bacteria, the antibiotics work in the same way, but palliative care is something that's inherently cultural because of the human side of it, and because of we're dealing with these big cultural, very personal things. And I think our field is having the reckoning of, palliative care came from a place and a time where it was born out of a late 1900s white middle income or middle high income class culture in the UK. And that's not everyone. And that some of the things that we norm, like that have historically been viewed as part of a good death, like a death at home, is not for everyone. It can be beautiful to have a death at home and really peaceful. And it can also be stressful for the family that's trying to manage it. And so having very open conversations and sort of trying to get away from any norms that, like, starting from the place of kind of humble curiosity of saying, like, can I ask you a hard question? Have you thought about what you want your death to look like? Or have you thought about what your child's death to look like? And not always, but a lot of times people have. And if they're able to go there and if we're able to guide them there, it can be a really productive, really important conversation about helping them think about what their view of a good death is. And then we can do our best to try to meet it. But for some people, it's at home. For some people, it's in an institution. For some people, it's in the children's hospital where they've gotten all of their care for 15 years because they just feel so at home there and know the team and know the staff and know the place. And so there's not a lot of, I think everyone deserves to have good pain and symptom management. And out of that, I think everyone deserves to have sort of the end of life look the way they want it to.
Yeah. And I want to bring in, so you work in Texas, it's pretty diverse, I'm talking about cultural barriers and honesty. Because if I would think, I come from a culture personally where it's more based on hope and faith and not honesty, like rather not tell or rather not say. And American culture is like totally different, where it's you want to be honest to the most extent. So do you come across that where people are like, I'd rather not know, or I'd rather not tell the child, or things like that?
Yeah.
How do you balance that?
Yeah, absolutely. And I'd also push back a little that I would say, I'm not sure I think hope and faith are at odds with honesty. Yeah. I think you can be honest and open and help people maintain their hope and faith, and that those two don't have to be mutually exclusive if we're doing it right. Yeah. But I think very much it's another one of the myths and sort of the stigmas we hear is like, we didn't want to consult palliative care because we didn't want to take away hope. And none of us have the power to give or take away hope. Hope's a thing. It's not a thing either. It's an act. It's an action. It's something people do. And so much of our conversation is about, tell me what you're hoping for, and let's figure out how we can work for that. And also, while we're working towards that one main hope, tell me, are there other things you're hoping for? And oftentimes, the prime hope may not be possible if somebody's prime hope is surviving and they're unable to survive. But all the other hopes they hold can often be very deliverable. But I think very much so, if somebody, either themselves or for their child, feels it's important that they don't know what's happening to them or that they don't know all the ins and outs of it, we want to honor that. And to me, I think any request like that is the beginning of a conversation, not the end of a conversation. And not to push back or to disagree with somebody's culture, but to really find out where they're coming from, to make sure that we can honor not just the request, but what's behind the request. And so like a study we talk about a lot was one that was done in, I think, Norway, where they followed up all, because they have a national healthcare system and have data on everyone. They followed up retrospectively with all of the children that died from cancer in the country over a 3-year period and called the parents and asked them, among other questions, did you talk to your child about the fact that they were dying before they died? Do you think that your child knew they were dying? And do you regret your choice? And what they found was that most people felt good about their choice, whichever it was, which I think is also heartening. And I'll tell families that, like, whatever you choose will be the right choice for you. And while none of the families who did talk to their child about that they were dying regretted it, about a third of the families who didn't talk to their child about that they were dying regretted it, especially if they felt like the child maybe knew something was up, which I think is all children, because children are smart and wise and savvy and get it. And I'm not sure I've ever met a child who was dying that I don't think knew that they were dying or knew that something really bad was happening to them. And so I will talk about this with parents sometimes, not to say like this is what you should do, but this is what we know from other parents who have been in similar situations. And I want to make sure like you have all the information and like help us help you. And if ultimately the choice is that, yes, we don't want to talk to our child about what's going on, we absolutely want to honor that. And also for children that have a voice in it, I think we can ask them also and say, do you want to talk about what's happening with your body medically? Do you have any questions? Or would you rather I talk to your parents about it and then they can talk to you about it? And I think that works for a lot of our older and sort of young adolescent patients, that some very much want to be part of the conversation, some very much want not to. And I think we should do our best to honor both.
Yeah, that's important. Yeah, but most times I think you said we have to honor like you cannot override what the family is saying or the parents are saying. Yeah, but you can have a conversation.
Yeah.
It's probably off topic, but what is an appropriate age to talk to children about death? Is there an age?
Yeah, it's a good question. And there's no hard and fast rule, but some people teach. And a lot of what I know about this, I've learned from my child life specialist colleagues, who I think honestly get so much more training about developmental level conversations with kids than any of us do in pediatrics. Yeah. And some people talk about kind of the rule of sevens, which is like from 0 to 7, children don't really have an understanding of death. And from 7 to 14, there's a spectrum, but often death can be sort of, there's magical thinking about it, that like it's something that happens but may not be forever, and people can come back from death, and it can be more graded. And then 14 and up, teenagers have more or less adultish understanding of death. And so like within those sort of rough ranges, I think then also we want to meet each child and family individually where they're at. And absolutely we'll leverage our child life specialist colleagues to have those conversations and say, if the parents are down for it, talk to them and see where they're at and see what they know and what they understand about what's happening to them, so that if they want to be, they can be brought into the conversation. And there's some 17-year-olds that don't want to talk about it. And then there's some 5-year-olds that do, or there's some that maybe don't talk about it in words, but through play or in creation of songs or making art can process and talk about these things. And it's a time where we're real grateful to our expressive therapy colleagues and things like music and art therapy for creating space for children to be able to process what's happening to them in a multitude of ways other than just words.
So yeah, no, I agree, Chad. It was awesome. And that's a good pivot, I think, that to talk to them about these things too. Is there burnout in your field, or have you felt burnout, with these conversations about death and sorrow and suffering, grief?
Yeah. Yes and yes. And I think it's probably not for those specific reasons. I think I think anywhere in medicine, there's the things that we all struggle with, and there's the things that are hard. It can't be from that in our field, or we would be broken and burned out all the time, because that's most of our days, unfortunately, end up being the worst day of somebody's life. And so because of what I was talking about earlier, sort of the coping strategies we have of one, to feel like the time we spend helping somebody with that is time incredibly well spent and is crucially important and satisfying. But also because when it is hard, we support each other in it. I think burnout for us often is from some of the stuff I was talking about before, like the biases, or when people use their arm to bar the door and keep us from doing the work that we believe so passionately in from being able to be done.
This was such a beautiful conversation. I think just so much profound and important things I think that we don't talk about on a daily basis, and I really think that we should talk about. So grateful for you. Is there anything that you would like as a message to the physicians who are listening, or you wish they knew better, about death, dying, palliative care? As we conclude, do you want to say?
Yeah. I mean, my ask is get to know your palliative care colleagues, call them up, go to coffee with them, ask if they'll come give a talk to your group about how your teams can work together, because there's so much we can do. And I think the fear and stigma around it only hurts patients and families and hurts other healthcare workers. I mean, a big part of our team's work is staff support and being involved when something hard is happening at the hospital to check in not only with the patient and family, but also with our colleagues in other specialties to give them time to process what's happening with this and normalize that, this is hard. You're doing good work and you haven't done anything wrong, because despite your best efforts, one of your patients isn't surviving. So let's talk about that and figure out how we can help each other.
Yeah. And you talked about you use humor. And I was going to say, we don't have pediatric palliative care at our institution. So, I mean, all sorts of informational resources are helpful. Is there any tele-palliative care that you know about? The first question.
Yeah, absolutely. And
your channel too, and what resources are out there?
Yeah. And so I think for our team, we spend a lot of time doing, especially in the outpatient setting, doing telehealth palliative care visits for people that live too far to the hospital to come, or are unable to come, or just prefer not to come because it's more comfortable to be at home with their condition. We also spend a lot of time doing just-in-time coaching that it comes up a lot with adult hospices that don't take care of kids very often, that just have a lot of questions about pediatrics. And so being available as a support to those hospices to help them take care of the kids that they are taking care of. I think there's a lot of great resources out there. And I think Center to Advance Palliative Care is a great start, capc.org, to just get teaching and learning and ways to have these conversations. I think any high stakes communication training, I think Vital Talk is a really good example, is a way to bring that training to your institution and kind of upskill everyone outside of palliative care. And yeah, I think my website, it's really, it's a series of animated videos that it started by accident, and I made one, and now there's, I think, 70 some. And they're about mostly palliative care, but also about racism in medicine and gender bias in medicine and mental health stigma in medicine. And they're 1 or 2 minute animated videos to help people lean in that I think humor and analogy and animation can be kind of disarming, and that you think you're just watching a cartoon and then you learn something, or you're impacted, or you have a perspective shift about something. And so for me, it's honestly been a big part of my self-care too, that I love using them for teaching, but sometimes if something really frustrating happens to me, I'll make a video. And that was how the first one actually happened, was that I got a consult, and the doctor who was consulting me said what we hear a lot from our consults, which is, we think you could be really helpful, but don't say you're the palliative care team, and maybe just talk about pain, and definitely don't take away hope, and don't make the family sad. And have you considered changing the name of your field? And I came back, and as I was walking back to my office, had the thought, it's like calling the fire department and asking them not to talk about fire. That the bad thing's already happening, and pretending it's not and avoiding talking about it only hurts everyone.
Yeah, I saw the fire department one. I think, that's pretty cool. I'll tag it in the show notes.
Oh, thank you.
Yeah. I think we're almost going towards the end. I think I have just one more question. How can healthcare workers process? So we talked about we have to get comfortable with death, accept it, all those things. But any suggestions for coping strategies to process the grief that comes with death?
Yeah. I think just honestly to talk about, find what works for you. I think not everyone is a verbal processor. And I think some folks feel like they need time before they can debrief or process, but there has to be some way to process it other than just stuffing it down, which is the norm. And I think it's what we're either all explicitly or implicitly taught. And so I think our team will get asked to do debriefings for a lot of other divisions. And none of us are like specialized debriefers. We just go and we say, I hear you guys are having a hard time. Like, how's it going? And people open up and start talking because there's been an hour made in the schedule to talk about feelings, and people have a lot of feelings to talk about. And I think like it's not rocket science, or I say it's not pediatric palliative care. It's just like being a normal person that is there and creates space for people to talk and to listen. And some of it is getting over all the stuff that, again, I think some of this is American culture, overlying medical culture, but not saying things like, oh, it'll be fine, or like everything happens for a reason, or like you did your best. Like, people don't want to just be reassured. They want to share and they want to be heard, and not sort of say these platitudes that I think we've all been sort of acculturated with. And an example I always think of, we were doing one of these debriefings for another division, and at the end of it, the division head, who's lovely and thoughtful, said, thank you so much for doing this and coming. This was really helpful. I hope we don't have to do this again for a really long time. And I said, no, I'm sorry, sir. I think you missed the point. Like, you have to do this every day. And I think getting that frame shift of like, it doesn't have to take that long, but like making a few minutes every day to talk about that, we don't see normal things. We don't do normal things. And we should acknowledge that and spend some time kind of checking in with each other and talking about it.
Yeah, no, that's awesome. And that's important. I agree. And I'm glad you're saying it out loud and you're making these changes. I think I really loved this conversation. I think I was reflecting on myself because I think I have all those biases. I have all those issues. So
you're not alone.
Yeah. It was a good therapy session for me. Yeah.
Yeah. Thanks so much for having me and having this podcast and these you're doing all of these things I'm talking about and shining a light and encouraging people to have conversations about stuff that we don't usually talk about.
No, thank you for being a guest. I think we have a tradition on this podcast. If you'll stay with me, we end it with a poem. And I want to leave you with a poem it's by Rabindranath Tagore, and it speaks to the peace we can find even in parting. You may have heard it, but it's called Peace, My Heart. Peace, my heart, let the time for the parting be sweet. Let it not be a death, but completeness. Let love melt into memory and pain into songs. Let the flight through the sky end in the folding of the wings over the nest. Let the last touch of your hands be gentle, like the flower of the night. Stand still, O beautiful end, for a moment, and say your last words in silence. I bow to you and hold up my lamp to light you on your way. Thank you so much, Dr. Rubenstein, for doing this with us today.
Oh, I love that. Thanks so much for sharing it. And thanks for inviting me. This has been a really nice conversation.
Yeah, thank you.